RetinaRounds, episode number 197. Today's case, submitted by guest surgeon Dr. Shruti Bhattacharya from New Delhi, India, features a young patient with a total traumatic retinal detachment and no posterior vitreous detachment. This is a challenging case that tests your surgical strategy and patience in the operating room. Dr. Ehsan Rahimy and I will walk through the surgical decision-making and highlight pearls and pitfalls for managing complex, trauma-related RDs in young eyes. Thank you, Dr. Bhattacharya, for sharing this case. All right, Ehsan, welcome back to RetinaRounds. Today we're going to talk about a patient who has a traumatic retinal detachment. And the surgical decision-making here, I think, is really, really important. That'll be the sort of the basis of our discussion for the case. But this one was submitted by our guest surgeon today, Dr. Shruti Bhattacharya. She is a cataract and vitreoretinal senior surgeon at Visitech Eye Center in New Delhi, India. She is presenting this case of a 16-year-old male who presented 3 months after being struck in the eye with a tennis ball. The patient had a total white cataract. This lens was subluxated supranasally, and a preoperative B scan showed possibly a retinal detachment. What they ended up doing was stage surgery. So first they did cataract surgery. They actually implanted an IOL and then used a CTR given the zonular instability. And then after that, reevaluated the patient, and the patient clearly had, on fundoscopy, a total bullous retinal detachment. Apparently, there are also some fixed retinal folds inferiorly, but no apparent retinal break. So in this particular scenario, Ehsan, what are you thinking? You've got this patient, traumatic, young patient, the traumatic RD, now pseudophakic, and the fellow's coming to you and saying, "Hey, the patient's clearly detached, but there's no break that we can see." What are you telling your fellow in that scenario?
How soon after the cataract surgery were they able to verify that this was a total RD? Is this like months later or a week later? Or...
I don't have that information, although the patient presented 3 weeks after being hit in the eye with a tennis ball. And so I don't think that the timeline of the surgery was, months, probably
Sure.
maybe weeks.
Yeah, young patient with an RD post-trauma. I mean, the first things that come to mind is there dialysis present? Typically going to see this either in the infratemporal or supranasal quadrants with the impact of trauma, as we know. The other consideration is whether there's an IOFB, although I think they gave a pretty good history. Tennis ball injury is quite unlikely you're going to have an IOFB associated retinal detachment here. So my number 1, 2, and 3 on my differential is dialysis is likely present here.
Yeah, and that's what I was thinking too when I read the case history. So when there is a retinal dialysis, what's the best surgery for these types of patients?
You put a buckle on them.
Buckle. Buckle is the best thing. We've talked about this in prior episodes. More than 98% success rate with the scleral buckle. Obviously, there's a lot of benefit to doing that in a young patient with formed vitreous. There's no PVD, by the way, in this particular case, which we're going to take a look at right now. So
Quite interesting. Total RD and no PVD.
total RD, no PVD, no visible break. And the plan here was to do a vitrectomy
It's an
with a
interesting
fluid
choice.
exchange, laser, and then silicone oil tamponade. So that was the plan going into the case. So let's see what Dr. Bhattacharya did here. Okay, so and I think at this point in the case, maybe a core vitrectomy is being performed here. You can see the RD, it's a total RD. I'm not quite seeing the fixed retinal fold. Certainly, there are corrugations of the retina. That's something that we can see with retinal detachments, but they're putting in some triamcinolone here and now trying to induce the PVD. And it looks like in an effort to try to aspirate an edge of the vitreous, some of the retina got incarcerated there, just infranasal to the optic nerve, and it looks like there might be a little bit of a iatrogenic retinal break there. Any tips that you have here in patients where you are doing a vitrectomy, the hyaloid's still attached, and the retina is in this case totally detached? Anything you can do to try to decrease that risk?
I think this is a big reason we try to stay out of these eyes. Even if it needed to be staged, I would still opt to just put a buckle on and come back and check later. Sometimes the effects from the buckle are enough to induce a PVD during that postoperative period, or at least loosen up the hyaloid more. But if you're in this position here and you're in the case, at least you want to release the hyaloid off of the nerve and around the macula. And I wouldn't get too aggressive pulling out into the periphery because this is where I'd probably want to start introducing perfluorine to be kind of a third hand, so to speak. Um, you may switch to a bimanual technique here, get a chandelier. You definitely really want to avoid iatrogenic breaks. In these eyes, a young patient, they have very sticky formed vitreous, and you got a total RD underneath. These are very tricky cases. I mean, so I think the best tip is to try to avoid being in that type of a position in the first place. But they had an own goal there at the beginning here, but they're doing a really nice job actually working through this, and they're slowly releasing the hyalid here, and they're kind of achieving the steps of the surgery here. So far, doing a nice job.
Yeah, I agree with you. I think that it's difficult for all the reasons that you outlined, but they're really being patient and not giving up. Obviously, the a critical part of the surgery here, if you are going to do a vitrectomy, is to elevate the posterior hyaloid. I think not engaging the vitreous too far peripherally is a very good piece of advice that you gave. And in these cases, even if there is a total RD, sometimes it's a bit asymmetric. I think that the inferior retina initially was a little bit more bullously detached than the superior retina. And so perhaps when you are aspirating with the cutter, trying to engage any vitreous that's there, it probably would be a good idea to point that cutter mouth away from the more bullously detached
Now, is
retina.
that a dialysis there?
That's exactly what that is. I think that's a dialysis, and
It
it's
looks like your
exactly the
dialysis
quadrant
there. Yeah,
where we would expect it. It's in the supranasal quadrant.
yeah.
This break more posteriorly, I think, is that iatrogenic break, and then they will end up putting in silicone oil for this patient.
That pretty in that position where you're, early in the case and you're seeing this hyaloid, it's sticky, it's form. I mean, will you sometimes come in and throw a buckle on after you've initiated a vitrectomy? And people have different feelings about that and the ease at which it is to do something like that. But what are your thoughts?
Yeah, if I think that a buckle is going to improve the outcome based on what I've seen intraoperatively, I don't, if I'm thinking about it, I think it's probably a good idea just to go ahead and do it. It's not that hard to do. I mean, what I'll end up doing is I'll take my trocars out where I'm doing the conjunctival peritome. And then when I take the trocar out and then I initiate the peritome, once I have a visualization of that sclerotomy, I'll put the trocar back in. And then when I get to the infusion line, I'll just switch the infusion line to one of the trocars that's already sort of on the bare sclera, and
Mhm.
then continue the peritome and then replace the infusion line where it should be. So the fact that trocars are in place is not a reason not to, to be afraid of doing a conjunctival peritome. It's not that complicated to do. I've had some colleagues actually just go posterior to the trocar even.
Mhm.
That's fine. Some people they prefer to do a conjunctival. They prefer to do their peritome a little bit more posteriorly. It's not my preferred practice, but some people do that. Um, and then it's just a matter of also making sure that there's adequate anesthetic on board, so doing another subtenons block, letting your anesthesiologist know, hey, this is going to be a little bit longer, so that they can, do their thing to make sure the patient's comfortable during the muscle manipulation and things like that. Um, so yeah, for me, if I think that I see something intraoperatively, I'm not dissuaded by the fact that I've started with a buckle that I can't, or started with a vitrectomy that I can't then add on a buckle. I think
Mhm.
got to do what's right for the patient in that moment based on what you see. How about you?
I agree with you. It's more straightforward when we know going in, I'm going to do a buccal and a vitrectomy. But if you're starting with a vitrectomy, and like you said, if in that case we're in the eye, I'm like, you know what, I think this would benefit from a buckle. Just going to go ahead and do it. Although for me, the thing that's maybe slightly different is I like to put all my buckles asleep. I don't usually do them under local. So we discussed the possibility of the need to convert them to general. And then we just pick up from there.
Yeah, yeah. I've had anesthesiologists go both ways. Some anesthesiologists feel very good, and I feel very comfortable with them doing the buckles under MAC. Others, I think it's better just to put them under general. Also depends on the patient. Younger
Yeah,
patients, they tend to be a lot more sensitive, and so especially young men, for whatever reason, they tend to be a little bit more sensitive during buckles. So,
absolutely.
I think general for those patients is a good idea.
I was even going to say this particular patient, I would have my practice pattern, he'd be going to sleep anyway for the surgery, even
Yeah,
for an attended MAC
yeah,
vitrectomy. He's a young male, he's going to sleep.
yeah. So, I think the key thing for this case is just in patients who don't have a PVD, especially young patients, really think about buckling for retinal detachments, and then definitely in the setting of trauma, really look carefully for potential dialysis because those can be most effectively treated with the scleral buckle.
I wonder even if you just put a buckle on this patient. I didn't really see fixed retinal folds as you alluded to. Probably didn't even need to drain anything, and that fluid would eventually probably would have gone away. It didn't really seem super bolus, but you could either put a buckle and do an external drainage or not.
Yeah.
You probably had a good outcome, but looks like the patient did really well.
Yeah, I mean the surgery overall I thought was well executed with that surgical plan, and just really want to thank Dr. Bhattacharya for sharing it with us because I think there's a really important learning points to be gleaned from this case.
Absolutely. That's why I don't play tennis anymore. Thank you for sharing a great case.
If you enjoyed this
Thanks.
video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.